Hello, good evening. I wanted to pop on here live because I wanted to talk about something that came across my Instagram that I thought would be useful to talk about. And mainly, I wanted to bring this up because I see this all the time in my practice with menopause and perimenopause care. And it's quite frankly really frustrating. So I want to bring up um, the idea of a Dutch test and doing a Dutch test before being on HRT and what that means and what that can look like and how this changes or doesn't change menopause care. So I saw this post on Instagram and I'm not going to go and talk about who it was, but I see these types of sentiments all the time, and so it's just time to address it. I see the Dutch test mentioned in a lot of spaces, and so we'll talk about that and why I think that it is a silly way to be moving forward here. But the post here basically says that um, I wish women knew, X, Y, and Z before going on HRT, which is hormone replacement therapy, and they're talking about how without a Dutch test, you are missing critical information that changes everything about a hormone protocol should be built. And so they're talking about the fact that we're looking at how you metabolize estrogen. And if you are favoring the wrong pathway before starting estrogen, this pushes you further in that direction. They talk about the cortisol curve and the fact that if your cortisol is low and spiking, HRT is not going to fix your sleep and mood. Talks about your adrenal reserve um, and about DHEA. They're saying that the protocol is not going to work if we don't know this. They're talking about androgens, so male hormones. They're saying basically, if we don't test DHT, which is again something that testosterone can go into, then this completely changes whether or not we add DHEA or testosterone to the protocol. They talk about what your estrogen is actually, or sorry, what your progesterone is actually doing, saying that if we don't, do this Dutch test, we're not going to know whether or not we should be giving you an oral micronized progesterone or not. And I have a lot of problems with a narrative like this because not only is it not true, but I think this actually creates a harmful narrative for women who are looking to get support in menopause and perimenopause care. And I'm going to tell you why I think this is a problem. The growing narrative behind this Dutch test drives me nuts. But let's define, for anyone who doesn't know what a Dutch test is, let's just define what I'm talking about. So the Dutch test is a dried urine test for comprehensive hormones. It is a private, out of pocket, often around $500, that measures hormone metabolites, estrogen pathways, cortisol patterns, and some other organic acids. I'm going to talk about why, in this setting, I think it's a really poor idea to run it. And part of why this post, I think, is really fear mongering and um, driving a lot of mistrust in a population that is already struggling to make these decisions. So, first of all, this is being positioned in this particular post as if it is, what we need to do in order to prescribe safe or effective hormone therapy. Okay. And that is absolutely not supported by any evidence. This matters because the audience that we're talking to is perimenopausal women. We are already symptomatic, already feeling dismissed, already hesitant. A lot of the patients I talk to are already hesitant or scared of starting HRT. And so now we're adding in this layer and we're saying there's a $500 barrier framed as necessary, and it's actually going to change the way that we prescribe and the decisions that we make. And in my opinion, that is delaying care. So let's talk about what is actually evidence based in menopause care. So, first and foremost, and I've talked about this before if you've heard me talk about it, menopause and perimenopause are a clinical diagnosis. Okay. We diagnose based on looking at your symptoms, based on looking at your menstrual history, based on looking at your age. And I've talked about this before. If you are below the statistical age and stage of perimenopause, then we do a lot of, deeper digging. Might look at your hormones over a month, let's say, a period of time. I'm talking specifically about the application here in perimenopause and menopause. Okay, so if you don't have a period for 12 months, you're in menopause, unless you're pregnant or you've been diagnosed with PCOS or you have a thyroid issue and you're like, 31 years old. Like we have to look at all of the pieces, put it into context. But when we look at the guidelines consistently across the board talk about a diagnosis based on symptoms and menstrual pattern. Hormone testing is not routinely required, and your hormone levels fluctuate. And so when we're doing said testing, this does not change our management. The guidelines also consistently say that HRT prescribing is based on symptom burden. So, do you have hot flashes, night sweats? Or is your mood a problem? What else is going on? Age and timing. Again, if you're over the statistical age of perimenopause, walks like a duck, talks like a duck, it is, right? We look at your bleeding history. We look at, you know, if you're 48 and your periods are irregular, you're in perimenopause, and based on your other factors, you may or may not be a candidate for HRT. We also look at your clot or cardiovascular risk. We look at your breast cancer risk. And hormone therapy is titrated or dosed to symptom relief, not to lab values. And so when we try to insert in the idea that we are going to do this Dutch test and you're going to have to pay for this test before you can get a beneficial dose or a precision dose of the HRT, this is a completely wrong and false narrative. And so the claim in the post that I shared was that the Dutch test is basically needed for better prescribing. And the idea that people are pushing is that if you don't do this Dutch test, you're not going to get the proper prescribing like you should, which is problematic to me because it is completely a false narrative. So here's how we already individualize menopause care or perimenopause care using HRT. We don't use urine metabolites. For example, if we're selecting a progesterone, if a patient has poor sleep, nighttime waking, feeling anxiety, or that wired feeling, this pushes us towards the selection of oral micronized progesterone rather than a synthetic progesterone because we know that crosses the blood-brain barrier. We know that it works on GABA receptors. We know that there's evidence that oral progesterone improves sleep. And so this is where we look at symptom-driven prescribing. Now, the post that's talking about how we need to do the Dutch test to look at progesterone is saying that, if your progesterone is low, which, spoiler alert, I can tell you it is because in perimenopause and menopause, you're ovulating a lot less. The quality of eggs that you're ovulating are going to be a lot lower. And as a result, you're going to make a lot less progesterone. And so as a result of that, we know that, if we're testing your progesterone, it's going to be low. That's not a shock to us. But the way that we choose progesterone has nothing to do with something that we'd find on a Dutch test. When we look at the estrogen route, again, we're looking at the risk factors. So we can either give estrogen topically on the skin with a gel or a patch, or we can give it orally. And if a patient has insulin resistance, they're overweight, they have high blood pressure, they have elevated cholesterol, we look at their overall risk and we say, they have an overall, like maybe they've had a history of a clot or a stroke, maybe they're on blood thinners, whatever the case may be. We say, okay, let's prefer the transdermal estrogen. Let's put estrogen on the skin rather than taking it orally. And that is because when we put it on the skin, we avoid that first pass liver metabolism. So, meaning we don't send the hormone through the liver, which when we send the hormone through the liver, we increase the clotting. And so, when we do a topical estrogen, we don't have that. We also have less impact on clotting factors. And it's better if you are the person that has a higher cardiometabolic risk profile. And that risk is based on other tests we do in medicine, not a Dutch based medicine profile. In fact, I'm not even sure the Dutch has the capacity to look at any of these factors. And then also, we know that hormone levels don't equal symptom response. So when we look at after we've dosed hormone replacement therapy and we're trying to determine whether or not we change a dose or we, change something about the protocol, we're certainly not relying on hormone testing in any capacity. There is evidence showing that serum estrogen levels does not reliably predict your symptoms. So if your estrogen levels are high or low, certain people can just experience different menopausal symptoms based on those levels. We know women with similar levels, estrogen levels, can feel completely different. And we also know that increasing the level does not guarantee symptom relief. In fact, if we take oral estrogen, this can actually produce a higher serum level of estradiol, But if we put it transdermally on the skin, we see similar relief compared to the oral, but it's not going to be as high in the serum, right? And that doesn't equal less symptom relief. In fact, we've actually seen them be the same. And so there's no number that we're chasing when we're looking at the hormones in the blood, for example. And also, there are people who are referred to as non-responders or poor absorbers. And so these are patients who, use estrogen. They have measurable levels, but they still have symptoms. Maybe we're at the max dose and their hot flashes are still not gone, or maybe they're at the max dose and they still have, X, Y, and Z going on. Um, or there's people that have low levels in their serum and they feel fine, right? And so when we look at the guidelines across the board, the overarching idea is that there is uncertainty around interpreting single estrogen levels, and symptoms may persist despite increasing the dose. So, serum or urine levels do not reliably tell us who will respond, who won't respond, or why. And there's absolutely no evidence that Dutch can tell us anything about whether or not you're going to respond or how well you're going to respond to hormone therapy. So let's talk about what the Dutch test actually shows us, and we'll talk about kind of what we're missing. So the Dutch test is the dried urine test, and it measures hormone metabolites. It shows patterns of how those are metabolized, and it reflects trends. What it does not show is treatment response, clinical outcomes, symptom severity, safety, or risk in any sort of validated way. Doing the Dutch test does not tell us whether or not you are at a high risk and should not be put on HRT. There's also no strong evidence that if we do a Dutch test, that improves menopause symptoms, that it improves HRT prescribing, that it reduces risk, or that it improves quality of life. And so any notes to the contrary saying that you should be doing this test is inaccurate. One of the things that's often looked at and talked about when my patients bring up a Dutch test is to do with the estrogen pathways. Okay. So, estrogen, when it's metabolized, can go through three distinct pathways: 2-OH, 4-OH, and 16-OH. And when we look at the different pathways, we do see that specifically the 4-OH pathway can actually create DNA damage. And we see this as, being a risk factor for increasing the risk of certain cancers. Okay. Now, this is theoretical. The theoretical idea is that 2-OH is protective, 4-OH is dangerous, and 16-OH is more estrogenic or proliferative. But when we actually look at the data, we see that studies on estrogen metabolites and breast cancer risk are inconsistent. When we look at larger studies, we see a weak or non-significant association. When we look at the ratios, a lot of times we're looking at the ratio of like 4-OH to other types of estrogens, and we see that there's no systematic reviews that support using these ratios in any clinical setting. And even when we do see these associations in certain research, they're not strong enough for us to say, when we run this test, we can see what your risk is so that we can make an informed clinical decision on whether or not you should start HRT. And it certainly doesn't translate into changing your treatment decision. And when we do testing in general in medicine, when we run a test, the goal is to find out information that we never would have had before, to make a decision that we wouldn't have been able to make otherwise. And so the test that I run, I try to make sure that I'm saying, this test is something that I would not have been able to answer the question or make a treatment plan without doing. If I can make a treatment plan, if I can do something for my patient that I know is going to impact them in a positive way without doing the test, I'm not going to run a test. And that's where I've kind of landed over the years with the Dutch test is every time, early on in my career, I've run a Dutch test. And not only is it expensive, but it doesn't get me anywhere different. And when it comes to menopause and perimenopause hormone therapy, it is absolutely not necessary and does not change the plan. And that is the goal. Like, does it change the decision we were going to make or how we were going to prescribe or what we were going to choose? Does it improve outcomes if you have a Dutch test? No, right? And so There is no validated evidence that measuring any of those estrogen pathways is going to predict breast cancer risk. This is one of the risks that we talk about when we talk about hormone replacement therapy is over that 6 to 8 years, depending on what type of progesterone you're using, we can have a slight increased risk in breast cancer. But there's no evidence that says that if we measure those metabolites, we then know better, right? So the reality is the pathways are real, but the clinical application of using these pathways has not been established at all in this space. Now, coming on to the cortisol adrenal claims that I hear all the time. You'll often hear your cortisol curve is off. You need to fix your adrenals or your HRT isn't going to work. The reality is your stress physiology matters. Looking at your sleep matters. Your nervous system matters. But adrenal fatigue is not a recognized medical diagnosis. I am often looking at a nervous system perspective rather than a cortisol or measuring a cortisol pattern perspective. Because at the end of the day, the nervous system is driving a lot of that activity that you're feeling or how you're feeling. And we know that the nervous system is going to be a lot more responsive to kind of like your daily things that you're doing. So, things that I use will give us a more real world experience looking at things like your HRV on your watch, if you have a device, your stress scores, your sleep scores. That can give us a lot more, real world data and data from day to day than a single, Dutch test that looks at a number of points or a single even serum test. I don't really even love testing cortisol in the blood because again, my question is what does it change, right? And I'm not saying we don't treat someone's stress response. I actually think it's really important and I do it a lot of time in clinical practice. But what I'm saying is that we don't need a Dutch in order to understand it, evaluate it, and create a treatment plan that makes sense. I can look at your sleep data. I can look at your life. I can look at the stressors. I can see what your HRV is or not. I can see what your blood sugar is because a lot of times we see a stress response in an insulin glucose challenge. And so I'd rather you do a $30 insulin glucose challenge to give me a lot more data about your metabolic health and about your risk and about potentially the impact of a stress response than to do a Dutch test because there's so much more I can do with that, right? So the nervous system is really important. That's number 1. And I think this is what happens. We take things and we cherry pick them to kind of make it suit what we're trying to prove, right? So in this case of the Dutch test, we're like, okay, so, we know the nervous system's important and HRT is not going to fix the nervous system. So we need to make sure we do this, do this Dutch test before we can do anything, which isn't true, right? It's true that we need to look at the nervous system. It's true that we need to look at your sleep and your stress, but it's not true that we need to do a Dutch test in order to understand that information. And then outside of menopause, is the Dutch test useful? We could have a whole conversation on this. Ultimately, there is really no validated role for the Dutch test in endometriosis, in PCOS. We can look at some of the metabolites, but again, my question is what does that change in our treatment plan? For my experience, it's really never changed anything. And so I am further inclined to do more blood work, to look at insulin, to look at inflammation. We know that the Dutch test hasn't been shown to improve fertility outcomes. And again, if we're actually in a space in life where looking at hormones actually makes sense. So if you're younger in PCOS or you have endometriosis or you're struggling with fertility, or we might think you're in perimenopause, but you're like below the statistical age. And so we think that it's appropriate to test some hormones. I love using Mira, right? We can do blood work, but Mira actually gives us urine hormones and we can do that over time. We can actually see how your estrogen, progesterone, FSH, and LH are moving throughout the month. And that gives you a lot more data rather than, one snapshot in time that's looking at a bunch of metabolites that clinically don't change the outcome, don't change the picture, right? And then, when we look at the biggest kind of point of contention here is what the Dutch is distracting from, right? When we're spending all of this time and effort getting a dried urine test, we are missing a whole other workup. I would always prefer my patients do that whole other workup, which looks at proper blood work, comprehensive blood work, right? Sometimes we even do gut tests. I'm not against doing functional testing, but I only want to do functional testing if it's going to change the way I move forward. I only want to do functional testing if it's going to make a clinical decision different. If I was going to go here, if I was going to make a left and a test causes me to make a right, then it was worthwhile to do that test, right? Focusing on a Dutch test, again, when we look at HRT as a whole, sometimes what happens is women are really frustrated and they have all these symptoms. And the reality is, everything looks like perimenopause and everything can happen in menopause. And so we don't know, are the symptoms from menopause or are they from something else? And the something else is, I think, where a lot of the functional practitioners can start to make some of these claims, right? Because we can say, well, if you don't do a Dutch test, like HRT isn't going to solve all your problems. And that's true. I always say to patients, we use it as a tool. We use it as a tool and we say, what can this tool fix? But, you know, we have to look at the rest of the picture. And what a Dutch test doesn't look at is an iron deficiency, a thyroid issue, insulin resistance, inflammation, nutrient deficiencies. It doesn't look at the gut. It doesn't look at mental health, like the things we can't test necessarily. The mental health assessment, maybe getting a sleep study because we have sleep apnea. Is that why you're so exhausted? HRT or testosterone is not going to fix that, right? And again, when we're actually identifying risk, if we're actually identifying the tests that we should use in order to make a clinical decision, things that are going to actually change our clinical decisions, the less sexy markers are the ones we're looking at. Insulin, cholesterol, liver enzymes, inflammation. Because if those things are off, if those things are super high, I might say to someone, yeah, we're not doing oral estrogen, even if, that product makes sense for you because the cardiovascular risk is so high, right? And so that actually changes our clinical decision making. And I've seen patients having anxiety in perimenopause, but they have a thyroid issue that hasn't been addressed and they have super low iron. So that really makes sense, right? Now, when we look at gut health, this isn't going to change how we prescribe HRT, but gut health can look at inflammation. It can impact estrogen recycling. It can impact hormone metabolism. It doesn't determine HRT prescribing. You could still get it or you could not, but it does help us understand the bigger picture and the other things that we need to work on. And there is emerging evidence that the microbiome interacts with estrogen metabolism, that menopause alters the microbiome and perimenopause alters the microbiome. We know that hormone replacement therapy may influence the microbiome, and this matters for inflammation, metabolism, and your overall symptom burden. But this is not validated for making HRT decisions. See the difference, right? And so this is, in my opinion, a patient care issue because we are dealing with patients who feel terrible, feel dismissed, who are already hesitant about HRT. They already have questions. They already might have a family doctor who's super unwilling to even look at them and talk about HRT or to have any of these risk benefit conversations or to bring up anything because they are, nervous about it or they don't have much experience. And then these women go online, they go on Instagram, they go on TikTok, they go wherever, and they see a really clickbait reel or TikTok post or whatever that tells them, I wish more women knew that this test, this $500 test, was critical before they went on HRT. And then women are like, oh my God, I was already scared. I was already scared to go on HRT. I went on because I pushed for it because my friend said it was going to be a good idea. Now I'm scrolling Instagram and this is telling me that maybe it's not a good idea. Maybe I've jumped the gun. Maybe I've missed something. I should now run and go to this Dutch test. And on that particular post that I shared, there are so many comments, Dutch test, because she's going to send like a code or something for them to buy the Dutch test. There was no evidence that it improves outcomes, improves safety, improves decision making. It, in my opinion, delays care, increases anxiety, increases confusion, adds unnecessary cost when healthcare for women is already costly, right? If you're going to a functional practitioner, you want to look at things from a holistic perspective. You want to look at all the other pieces. HRT is a tool, but we don't need to block that tool with an unnecessary test or make women believe that they need to do all these things before they start HRT. At the end of the day, the Dutch test can measure hormone metabolites. The estrogen pathways are biologically real, but there's no evidence that links them to changing or increasing risk when it comes to HRT. Cortisol patterns reflect your physiology, but we can look at the nervous system in a lot less expensive ways and a lot more effective ways. And there's no strong evidence that using the Dutch improves clinical outcomes. There's no evidence that it is required to safely or effectively give you HRT. So, kind of in summary, we don't need to make menopause more complicated than it already is. Hormone therapy is prescribed based on symptoms, safety, and the patient, not a $500 urine test that hasn't been shown to improve outcomes. So, I wanted to just share this message because I think it's really important that we all understand that. And I think there's a lot of things online that it's really easy to, get sucked into or think that we have to do something or make a different clinical decision. And that is just not the case.